Hello, everyone, and thank you for tuning in to another episode of the Oncology Brothers podcast. I'm Rahul Gosain here with my co-host and brother, Rohit Gosain. Today, we're excited to dive into the world of acute myeloid leukemia, AML, which continues to be a complex area in hematology. To guide us through the current landscape, today we're thrilled to have Dr. Mikkael Sekeres, Professor of Medicine and Chief for the Division of Hematology at the University of Miami. Mikkael, welcome.
Thank you so much for having me. What a privilege it is to be here.
Mikkael, thanks so much for joining us. Diving into the space of AML, which is rather very overwhelming, especially from community oncology standpoint, because we don't get to see a lot of these patients, and rightly enough, because we have to partner up for these patients with tertiary or quaternary centers, especially right the minute we see acute leuk, that's where these patients are headed to. And after transplant and after initial induction therapy, if they do receive one, they do land into community settings. So it is important for us to be informed about this particular disease. And importantly, now we have some oral options as well as now hypomethylating agents with venetoclax, which are being administered in outpatient setting. Mikkael, with all that in mind, can you please walk us through your initial approach, mainly your diagnostic workup, and some of the risk stratification for acute myeloid leukemia?
Absolutely. So it's a great question also, and I'm not just saying that because I'm a leukemiologist. It's really controversial what to do. We used to divide patients like this into whether they're older or younger. And we would make that dividing line somewhere around the age of 60. And you can imagine that as leukemia doctors aged in their career, they kept moving that line of older farther and farther away from their own age. So we joke that older adult in AML is someone who's about 10 years older than you are. So, we also were at risk of ageism with this. And there are a lot of times where we would see, even in the scientific literature, that older adults weren't treated. There was a study that was published in 2003 that showed that fewer than 1/3 of older adults, people in that study defined as 65 and older, received any type of therapy for their acute myeloid leukemia. So now we've moved more towards, this vague notion of fitness. Is a patient fit to receive intensive induction chemotherapy? That's the one where they're in the hospital for 4 weeks. Or are they not fit for that intensive induction therapy? So we need to think of other regimens. So maybe we should start with those patients who are quote unquote fit and can receive intensive induction chemotherapy. When we think of these folks, we divide them into relative risk, a lot of times based on the genetics of their leukemia, or whether they have a background of myeloid dysplasia or an antecedent hematologic disorder. For patients who have a good risk genetic profile, and we define that often using the European Leukemia Net or ELN classification, those are folks who have an 821 translocation. That's the RUNX1 T1 translocation. Those patients who have an inversion 16 or a translocation 1616, that's the CBF beta MYH11 combination, or those patients who are NPM1 mutated but FLT3 negative, or those patients who have CEBP alpha mutations. That's kind of considered favorable risk. Those are patients ideally we send to receive intensive chemotherapy. Now, for intensive chemotherapy, that is the classic 7+3, right? 7 days of cytarabine and 3 days of an anthracycline or anthracene-dione. Typically, daunorubicin will use. Now, we may add on other drugs depending on their genetic profile. And what's implied in what I've been saying is that we need to do genetic testing at diagnosis, and we need to get it back quickly. So we published a study, gee whiz, I think it was back in 2008 in Blood, where we looked at how patients did, how long they lived, depending on how quickly we started intensive chemotherapy in those patients. And what we found is that for younger adults, those under the age of 60, every day matters. Every day you delay that start of chemotherapy, someone's survival may be affected. For older adults, it's probably not quite as important because often they have a leukemia that has evolved from an antecedent hematologic disorder. So it's not one of those raging leukemias It's something that's more smoldering and percolates for months. So we've got to get genetic testing back quickly. For those patients who have core binding factor abnormalities, we typically do add gemtuzumab, ozogamycin, or Mylotarg to that classic 7+3 regimen. We do that based on some large studies that have been conducted that indicate, if not an overall survival advantage, at least a disease-free survival advantage for those patients who receive the gemtuzumab. So we find out, do patients have a core binding factor abnormality? If they do, we tend to add gemtuzumab.
Can I take a quick pause here? We keep bringing up the genetic testing out in the community. Do I do this on peripheral blood if there is high blast cell count, or this has to be done on a bone marrow biopsy sample? Does it really matter?
Yeah, great question. So if a patient has circulating blasts, it's fine to do this on circulating blood. There have been some studies that show that molecular testing in patients with myeloid malignancies like myelodysplastic syndrome, acute myeloid leukemia, peripheral blood is about as accurate as bone marrow. It's not perfect, but probably good enough if you don't want to send someone through a bone marrow biopsy. There are now rapid NGS panels as well. We're fortunate at Miami and Sylvester to have one in-house that can turn these tests around, my word, in less than 48 hours. So if a patient has a FLT3 mutation, it wasn't that long ago, probably about 10 years ago, someone had a FLT3 mutation, and we would say that's very poor risk. And it's one of those rare instances in oncology, and you guys see more of this than I do because you treat solid tumors, one of these rare instances in oncology where the therapies that we've developed have actually shifted the risk of a previous poor risk factor to something that's intermediate risk. So we now have 2 drugs that are approved as FLT3 inhibitors that we add to the initial therapy of somebody with acute myeloid leukemia who's FLT3 positive. Midostaurin, that was the first one, and that's approved for patients who are FLT3 ITD or TKD. And then more recently, quizartinib, my disclosure, I was on the steering committee for quizartinib, and that's approved for patients with FLT3 ITD mutated AML. In both cases, we have randomized trials where these drugs, compared to patients who received placebo in addition to 7+3, actually prolonged patients' overall survival.
Mikkael, can we talk about the induction therapy? And then, of course, we'll dive into the FLT3 story as well. When we're talking about 7+3, cytarabine, daunorubicin, the other thing that we have an option of is the liposomal combination. What's the difference? Is a better drug? What are the outcomes, your practice, based on the data that's available today for the liposomal combination?
Yeah. For a patient who is quote unquote fit to receive intensive induction chemotherapy, another alternative in those who have what we consider kind of a poor risk morphology or a poor risk history, patients who have a known myelodysplastic syndrome prior to converting to AML, those who have a lot of dysplasia in the background, or those who have therapy-related AML, CPX 351 is approved for induction therapy, and that's a fixed molar concentration of 7+3. So it's fancy 7+3, right? And patients who were randomized in that trial did have a survival advantage when they received CPX 351 versus 7+3. It does have complications with it. One of it is prolonged cytopenias. The second is financial toxicity. It's very expensive. So for centers that have kind of a capitated care approach to treating AML, where they get a fixed amount of money for treating a patient inpatient with a 7+3 type of regimen, that can be a financial hardship for that center. So I think as a result of that, there hasn't been quite as much uptake in use of CPX 351 for patients in these categories. And in these patients, I still think it's acceptable to use 7+3.
Thanks for summarizing that. And now this patient has undergone induction therapy, and consolidation is certainly an option. In terms of the maintenance aspect of it, do you continue on with the targeted therapy, which is FLT3 positive patients?
Yeah, it's a great question. So after somebody undergoes induction chemotherapy and presumably that person goes into a remission, and for a younger adult, the chance of going into remission is probably around 70%. It's higher for those who have core binding factor abnormalities or good risk genetics. We then give them post-remission therapy in the form of consolidation or intensification. Typically, that's cytarabine based. So they receive Ara-C. Typically, they'll get Ara-C for about 3 or 4 cycles of therapy. Afterwards, there's a question of whether there's any benefit for maintenance. And this is where it's, again, a little bit controversial.
Right.
For those patients who are FLT3 positive, the studies that led to the approval of midostaurin and quizartinib did have a maintenance component to it. The FDA didn't buy it. The FDA said, that's great that you had a maintenance component. We're not adding that to the label. So maintenance FLT3 inhibitors is not part of the label in the US. It is part of the randomized trial. So I do think that it's acceptable to give maintenance therapy. And more recently, we've shown with quizartinib that patients who go on to receive maintenance therapy, particularly those who are MRD positive who don't get a transplant, seem to have actually a survival benefit to continuing to get that maintenance therapy.
So we've had induction, consolidation, depending on the patient in front of you, your maintenance option. You touched on this. Where are we putting transplant in this algorithm or this paradigm?
Yeah, great question. So certainly patients who have poor or adverse risk AML, those are folks we're referring for transplantation in first complete remission. Okay. We know that if we just continue with chemotherapy, the outcome isn't going to be great. We're talking about a 5-year survival that's less than 20%. Those are folks where we want to do everything possible to improve that overall survival. So we are recommending consultation with a transplanter early on. Increasingly, we're also looking at MRD status, and I mentioned that kind of in passing, measurable residual disease. We're assessing patients for MRD, and it's those patients, as you might predict, who are MRD negative who go to a transplant who fare much better than those who are MRD positive going to a transplant. We do not recommend transplant for those patients who have favorable risk AML. There is no advantage to getting a transplant compared to continuing with chemotherapy in those patients.
Now, moving along into the non-induction space, that was mainly induction related. And these are the patients that we will continue to see in our community settings, that is elderly or frail, though again, that class would be induction ineligible. How do you go about the treatment options here, particularly hypomethylating agent now being combined with venetoclax, azacitidine or decitabine arm?
Yeah, well, gee whiz, you hit the nail on the head with that, right? We have a new standard of care that we use for folks we consider ineligible for intensive chemotherapy, and that's a combination of a hypomethylating agent such as azacitidine or decitabine, along with the BCL2 inhibitor venetoclax. And of course, there was a randomized trial that was published in 2020 that showed a survival advantage for patients getting the combination that was approximately 14 months compared to patients who got hypomethylating agent monotherapy such as azacitidine or decitabine alone, where the median overall survival was closer to 8 to 10 months. So that is our standard approach. What is all over the map is how you treat patients. How do you dose them? How do you schedule them? My word, this is one of those examples where the FDA approved a dosing and scheduling regimen that in practice we can rarely give, particularly since the patients we're offering this to are older. Recall the median age of diagnosis for AML is about 67 or 68 years in this country. So a typical patient in my practice in South Florida is someone in his or her 70s, where I'm giving them azacitidine and venetoclax. We admit them to the hospital for the first week to monitor their side effects to it, particularly if there's any risk of tumor lysis syndrome. Then we treat them as an outpatient, 28 days of venetoclax and 7 days of azacitidine, for example. It is fewer than 50% of those patients, probably 25%, I can then give another 28 days of venetoclax to. And typically what we're doing is very quickly dialing that down to 21 days, 14 days, even 7 days, particularly in our octogenarians and nonagenarians.
You know, if you were to take 10 hematologists and ask how they're delivering methylating agents and venetoclax, you'll get 15 different answers here. Mikkael, coming back to the same patient population, someone who cannot get induction therapy, hypomethylating agents, venetoclax now has been standard of care. But any role of FLT3 or IDH mutations here, if we don't even think that they can tolerate hypomethylating agents, can we just target these mutations upfront?
Yeah, it's a really insightful question. So we don't have data that are strong yet for giving, for example, a hypomethylating agent and a FLT3 inhibitor upfront instead of giving a hypomethylating agent and venetoclax. So my practice is still to give those two drugs upfront in patients who are FLT3 positive. For patients who are IDH positive, then it's a different story. We actually have a phenomenal study that was conducted that randomized patients to getting azacitidine and ivosidenib, an IDH1 inhibitor, versus azacitidine alone. And patients who received the combination lived 3 times as long as those who got azacitidine monotherapy. So we do think it's acceptable in these cases to replace the venetoclax with an IDH inhibitor and treat patients like that. What we are debating actively is, do patients have better outcome if you give them azacitidine and venetoclax when they have an IDH mutation, and then when they relapse, give an IDH inhibitor? Or do they do better with the upfront therapy and maybe you reserve venetoclax for a second line approach, or maybe you go to a different approach? So that's actively being studied actually. So we'll have an answer probably in a few years.
These are certainly exciting times, just like any other malignancy, even in leukemia, with the targeted therapies available. Mikkael, at least from community standpoint, the dreaded concern has always been managing some of these side effects, at least that comes from acute or chronic, and then you combine that with these patients undergoing transplant, so GVHD comes along with that. Particularly focusing on AML and the treatments available here, if you could just briefly talk about some of the important side effects, that at least from the community oncology standpoint, that we should be aware about, whether that's hypomethylating agents or some of these targeted agents.
Yeah, I love that question. There's a dirty little secret about hypomethylating agents and venetoclax, and that is that we talk about it as therapy for patients who, quote unquote, aren't fit for intensive chemotherapy, yet it's almost as intensive as 7+3. We're just doing it as an outpatient in these older adults. And we realized when we first started giving these regimens, these folks were getting really bad fungal infections because they weren't on antifungal prophylaxis. So now we routinely give antifungal prophylaxis, with a major caution being that for a lot of these antifungal medicines, a lot of the azoles, they interact with venetoclax. So you have to massively reduce the dose of venetoclax from 400 milligrams a day to 200 or 100 milligrams a day. So one of the things we do, we give very comprehensive antibiotic prophylaxis where we're giving an azole, fluoroquinolone. We're giving acyclovir as well. And we're monitoring these folks for fever and neutropenia. And almost every one of these patients will bounce into the hospital at some point. These folks get profoundly cytopenic for a long period of time. So we monitor their blood counts 2 or 3 times a week, certainly during the first 2 or 3 cycles, to see whether or not they need transfusions. And we gear up our comprehensive staff of nurses, pharmacists, our blood bank, and our patients to set expectations that they're going to need very intensive, very frequent follow-up in the outpatient setting to receive these regimens.
Mikkael, again, one thing to reiterate, that dose reduction because of the drug-drug interaction is very, very, very important when we're putting these patients on these oral agents. So what if the disease is refractory to frontline treatment or relapsed disease? Mikkael, this is a broad topic, but briefly, can you touch on your approach here?
Sure. So, when we give 7+3 based therapy to patients who are fit enough to receive it, it is potentially curative. We do have a percentage of patients who are cured of their acute myeloid leukemia. For all comers walking through the door, the cure rate is about 30%. And that does include some patients who go on to transplant. So the uncomfortable truth about that is 70% of patients won't be cured. And right now, in 2024, we cannot say that a hypomethylating agent plus venetoclax approach is curative. We do have some patients who are alive 5 years having received it, and their doctors have stopped giving it now to see how they do. So maybe there will be a small percentage of patients who are cured with that, but we can't say that. We can't look our patients in the eye and say that right now. So most of our patients will relapse from this therapy. If somebody is FLT3 positive, we do have a drug, gilteritinib, that's FDA approved for relapse and refractory disease. It's based on an overall survival benefit. And what I'm seeing more and more is that people are switching up the therapy opposite from where they started, right? So if you have a patient who's not fit to receive intensive chemotherapy, they start off with a hypomethylating agent and combined with venetoclax. When the leukemia comes back, they're often getting cytarabine-based therapy, right? And sometimes actually those patients do become fit enough to receive 7+3, and they're actually receiving 7+3. For patients who started with 7+3, a lot of times I'm seeing that they're then being treated in the relapsed refractory setting with a hypomethylating agent and venetoclax combined. What you can also do for those patients who are particularly younger is give other cytarabine-based induction chemotherapy. So we're giving things like CLAG with a cladribine, NEC, so mitoxantrone, etoposide, and cytarabine. Those are still commonly used. Those still lead to a complete remission rate that's somewhere between 20 and 30%. For those patients who have IDH mutations, if they didn't get an IDH inhibitor up front, we certainly have on-label use of enasidenib for IDH2 mutations, ivosidenib and olutasidenib for IDH1 mutations. Finally, there is an approval on the books for gemtuzumab ozogamicin in a relapsed refractory setting. I don't see it used as often in that setting. It does have a low remission rate, does have some toxicities associated with it, particularly profound cytopenias, and for those patients heading to transplant, veno-occlusive disease of the liver. But it is something that you can think about for patients who really don't have any other options.
Thanks, Mikkael. Though this slide is getting complicated with more approvals, which is a good thing for our patients. Well, we have covered a lot in a very short period of time. Mikkael, thank you so much for walking us through this evolving and complex topic. For our listeners, let us go over a quick recap.
In today's discussion with Dr. Mikkael Sekeres from University of Miami, we touched on the current treatment landscape of acute myeloid leukemia, AML. Induction and consolidation chemotherapy, along with selected patients for allogeneic transplant, is still very critical. But we continue to see advancements in finding actionable mutations like FLT3 and IDH mutations.
Relying on these oral targeted agents can be a viable option in frail patients or someone who's not a candidate for aggressive induction treatment. Over the last few years, we have seen hypomethylating agents in combination with venetoclax as a very active option as well. It is important to consider the acute and chronic side effects that come along with these important interventions. Thanks for tuning in. Make sure to check out our other hematological malignancy discussions. We also look forward to seeing you in person at ASH 2024. We are the Oncology Brothers.